Masquerade Optic Neuropathy by Dr. Nakano.
Good afternoon, everyone. I'm very pleased to have this opportunity to speak to you today. I would like to present a challenging case from our Japanese hospital. I encourage everyone to think through the diagnostic process as if you are evaluating this patient yourself. Now let's move on. The patient was a 61-year-old male who presented with a chief complaint of a gradually progressive hazy vision in the left eye for approximately 2 months before visiting our hospital. His past medical history included bilateral sinusitis, for which he had underwent surgery around the age of 30. He quitted smoking at the age of 45, and although he drank alcohol daily, his intake was not excessive. He had no dietary imbalances. His only regular medication was an anti-allergic drug. Regarding family history of ocular diseases, his paternal uncle had glaucoma, but there was no other family history of visual impairment. Best corrected visual acuity was 20/20 in the right eye, but decreased to 16/20 in the left eye. Intraocular pressure was within the normal range bilaterally. The critical flicker fusion frequency, CFF, was 39.2 Hz in the right eye and 30.2 Hz in the left eye. The left eye showed a positive RAPD. No significant findings were observed in the anterior segment or media. Fundus photography at the initial visit showed no abnormalities. OCT did not reveal any thinning of specific retinal layers or disruption of the outer retinal structure. The optic disc showed no swelling or atrophy, and there was no thinning of the inner retinal layer in the macular region. However, despite these normal fundus findings, the left eye had severe visual field defects. Humphrey Field Analyzer, Humphrey 30-2, showed a mean deviation of minus 23.74 decibel with a decreased foveal threshold of 26 decibel. Goldman perimetry demonstrated generalized depression of visual sensitivity in the left eye, with both central and paracentral scotomas. The right eye's visual field was normal. Given the patient's symptoms, unilateral visual dysfunction in the left eye with a positive RAPD but no intraocular abnormalities, the suspected region is likely located between the optic nerve and the optic chiasm. What possible etiologies should be considered in the case? In the differential diagnosis of optic nerve diseases, the time course of visual dysfunction is a crucial factor. The time course varies depending on whether the underlying cause is ischemic, inflammatory, or compressive. The red line represents ischemic optic neuropathy, which has a sudden onset and follows an acute course. Vision loss occurs rapidly at the time of onset, and in most cases, visual function remains stable thereafter. The blue line indicates optic neuritis, which follows an acute to subacute course. Vision typically worsens over a few days to a maximum of about 2 weeks. In cases of idiopathic optic neuritis, spontaneous recovery usually follows. The green line describes compressive optic neuropathy, which follows a chronic course progressing over months or even years. Because of its slow progression, it is often challenging to distinguish from glaucomatous optic neuropathy. In this case, the patient's visual impairment gradually progressed over approximately 2 months, making compressive optic neuropathy the most likely diagnosis. The absence of retinal inner layer thinning in the macular region suggests that compression is occurring behind the optic nerve without causing retrograde degeneration in the retina yet. If the cause were ischemia or inflammation, it would be highly unusual for the optic nerve to remain unchanged 2 months after the onset, as Carmen-chan said. Therefore, we performed contrast-enhanced orbital MRI. However, an unexpected result awaited us. Surprisingly, no compressive region was found anywhere. Additionally, there were no sinus regions that could be suspected of contributing to the visual dysfunction, nor was there any enhancement of the optic nerve itself. We had to re-evaluate our diagnosis. RAPD can occur not only in optic nerve diseases, but also due to extensive retinal disorders, such as central retinal artery occlusion or acute idiopathic blind spot enlargement syndrome, AIOS, including Azure. If there was no abnormality in the optic nerve, the only possible explanation for the positive RAPD was retinal dysfunction, even though there were no OCT abnormalities. We therefore firstly asked the patient whether he had photophobia and night blindness, as these are suggestive of retinal damage. It turned out that both had appeared right around the time when the patient started to notice a loss of vision. However, no significant findings were observed on autofluorescence fundus photography, fluorescein angiography, or berries. It was only after performing a full-field ERZ that we were able to identify highly characteristic findings. Can you tell? We see a decreased rod response in the left eye and a negative ERZ in the combined cone rod response, where the B wave is lower than the A wave. In the cone response, there is a square A wave with a flattening of the last part of the A wave. These suggest on-type bipolar cell damage. This selective impairment of on-type bipolar cells is characteristic of melanoma-associated retinopathy, MAR. Let's review MAR. MAR is a subtype of autoimmune retinopathy, AIR. AIR is broadly classified into paraneoplastic AIR and non-paraneoplastic AIR. Within the paraneoplastic AIR category, there are MAR and cancer-associated retinopathy, CAR. MAR is a retinopathy caused by malignant melanoma, typically with metastasis, and is an extremely rare disease. The average age of onset is 57.5 years, with a slight male predominance. The main symptoms are progressive visual dysfunction accompanied by flickering or pulsating photophobia and night blindness. It is usually bilateral, although rare cases of unilateral involvement have been reported. It is often associated with a history of malignant melanoma, and the average time interval between tumor detection and the definitive diagnosis of MAR is 3.6 years. However, the interval varies widely, with reported cases ranging from as early as 2 months to as late as 19 years after melanoma detection. And importantly, in some cases, MAR may even precede the diagnosis of malignant melanoma, so careful attention is required. Fundoscopic examination may reveal optic disc failure, retinal vessel narrowing, mild retinal vasculitis, retinal pigment epithelium abnormalities, and vitreous cells. However, approximately half of the cases show no detectable abnormalities. ERG findings can vary widely, but since bipolar cells are often primarily affected, their dysfunction is reflected in characteristic findings. Like our case, a decreased rod response, a negative ERG, and a square A wave strongly suggest MAR. Additionally, in recent years, it has been found that MAR is caused by the production of antibodies targeting retinal proteins, particularly those that react with the cation channel TRPM1, which is produced in melanocytes and on bipolar cells. Our case involves a 61-year-old man whose main symptoms and ERG findings are consistent with MAR. Therefore, the diagnosis is MAR, meaning that somewhere in this man's body, a malignant melanoma must be hiding. We need to find it as soon as possible. However, no tumor was found. A thorough dermatological examination for melanoma was conducted, including a biopsy of a pigmented nodule on the lower jaw, which was diagnosed as a pigmented nevus. Considering the possibility of a primary nasal melanoma, nasal endoscopy was performed, but no significant abnormalities were detected. A liver mass was identified, on whole body CT, but further evaluation with abdominal ultrasound and MRI suggested it was a hemangioma. No other tumors were detected. In addition, anti-TRP-M1 antibodies tested negative. Therefore, his final diagnosis was NPAIR so far. How should it be treated? There is no established standard treatment for autoimmune retinopathy. In paraneoplastic cases, treating the underlying tumor is the highest priority. Additionally, systemic and local corticosteroid therapy, immunosuppressants, IVIG, and plasma exchange have been used empirically. In this case, we chose STTA as the local ocular treatment. 1 month after STTA treatment, the visual acuity in the REST-Y improved from 1420 to 2020, and the CFF increased from 28.3 Hz to 47.2 Hz. Improvements were also observed in the MD value of Humphrey 10-2 and the foveal threshold. A second STTA was administered 3 months later, and the patient has remained relapse-free for 6 months since the initiation of treatment. Additionally, a full-field ERG performed at the 6-month follow-up showed remarkable improvement. Here is a summary of lessons learned from this case. RAPD can occur even in retinal disorders. ERG may detect abnormalities even when OCT shows no significant findings. Remember the characteristic ERG findings of MAR. Prompt tumor screening is the top priority, but adjunctive local treatment can be effective. Since retinopathy can precede tumor detection, continuous follow-up is essential. This is the most important point. Thank you for your listening.
Thank you.